Hello, my name is Deborah Cohen, and I am a MAVEN project volunteer moderator. Thank you all for joining us today and our friends at Boston Healthcare for the Homeless, a great organization, and they are hosting today's session, which is Therapeutic CGM Training Program, given by Dr. Sushma Reddy. Dr. Reddy is an endocrinologist who has practiced in Port Huron, Michigan for over 28 years. She was instrumental in achieving Joint Commission certification for advanced specialty care in diabetes in both hospitals in her area, making them two of only 3 hospitals in Michigan with this distinction. On an outpatient basis, she has developed a successful boot camp approach to patients with uncontrolled type 2. She is passionate about CGM and currently consults to improve outcomes with CGM and other technologies. In addition, she has won the Michigan State Medical Society Community Service Award twice for her work with uninsured patients. She's an impressive person. And with that, Dr. Reddy, please begin.
Thank you, Dr. Green, for that introduction, and I will go ahead and share my screen. Yes, well, thank you all for participating and being here today for this presentation. And what I like to do is really make it interactive. So I will stop at different points to take any questions and really appreciate all your questions and interaction here. So let's go ahead and get started on using CGM to adjust insulin dose. Here are my disclosures. And as you know, this is accredited with the CME, as Dr. Cohen already alluded to. And you're familiar with the objectives, where we'll be going over the CGM data, how to interpret it, how to use it to adjust insulin dose, how to set your patients up for success, and how to incorporate it into day-to-day management. What I'm going to do first is go over the CGM overview and interpretation. We'll then move on to adjusting insulin for basal bolus regimens using CGM, setting the patient up for success, going over basal insulin, some case studies, and some of the clinical evidence. I'll kind of stop at different points to answer questions you might have that pertain to that section. So I know many of you already use CGM, and you've seen the impact of CGM in your patients. And you know that if a patient is using CGM, they no longer need to poke their fingers, so they don't have those sore fingers. They can actually see what their glucose levels are in real time, and they get alerts. So if they're dropping too low, they'll get an alert. And as we all know, that helps to prevent hypoglycemia because they can now get something and be treated for it. The neat thing too is they can see where their glucose is headed. So you see here on a meter, you know what your reading is. But if you have a CGM on and you have diabetes, you have an arrow. And this arrow tells you where you're headed. Think of those patients who tell you, Doc, I eat the same breakfast every day. I take 10 units of insulin for my breakfast, and one day I'm high and one day I'm low. And then they go, I give up. And why is that? That's because sometimes when they're ready for their breakfast and they need 10 and they want to take 10 units, this arrow is headed up. What does that mean? Well, 10's not enough. Maybe they need 11. And sometimes the arrow is headed down, which means 10's too much. Maybe they need 9. And that's what we'll go over today as we learn how to teach our patients to adjust their insulin using CGM. And we really want patients to participate in their care. We don't want to be the ones telling them, you do this, you do that, but rather it's shared decision-making. The patient is taking an active role in their care. And that's what CGM does. It empowers the patient. They can see the glucose data. They change their behavior. And in fact, my patients go, Doc, CGM has really changed my life. One of them called it his GPS. He was actually paying for the CGM out of his pocket. He was on a sulfonylurea and he had been scared to go to bed. But now that he had the CGM on, he knew exactly what his glucose was and where it was headed. And he kind of called, I said, what do you think, Laura? He goes, well, this is like my GPS. You know, in the old days where we had a car, we kind of got to where we needed to. And now that we have a GPS, we know exactly what we need to do. Well, that's what CGM is. And we know that when we do the meters, the patients are just poking their finger and we get one glucose level, one single point in time. And if we're lucky, the patient brings in a couple readings. But with the CGM, and this here is the Abbott Freestyle Libre in the back of the arm, you're getting glucose levels every 1 to 15 minutes. So you have so much more data and you know exactly what's going on with this patient. And so does the patient. Like if they eat something, they know what happened. So let's take a look at this patient. So this is a patient who comes into your clinic, brings in these readings, and you're like, wow, this looks pretty good, 70 to 180. So question for you now, this is your first poll. What would you tell the patient regarding their glucose control? And you can see the poll options. You'll see the poll come up in just a minute. You have 4 options there. Your glucose is under excellent control. Your glucose levels look good, but I need your A1C to assess your overall glucose. Your glucose levels look good, but I would like you to wear a CGM to get the complete picture or not share. So go ahead and let us know what you would tell the patient.
Okay, I'll give you about 10 more seconds here. Okay, I'm going to end the poll and share the results.
All right, so we see 33% would like an A1C, 56% would like a CGM, and 11% are not sure. All good answers, so let's take a look here. So for those of you who said we want an A1C, A1Cs, as we all know, is extremely helpful as we monitor our patients. But there are some problems with A1C. It doesn't give us the complete picture. Look at this. These are 2 patients. They both have an A1C of 6.8. And here is the glucose level. Here is time of day. You can see this top patient, the glucose levels are all over. Whereas this bottom patient is actually doing great, right within range. So as you can see, the A1C is helpful, but it's not giving us a complete picture. What does this also mean? If you see somebody in your clinic whose A1C is under 7, it doesn't always mean they're doing great like this patient. They could also have that A1C under 7 and look like this. So if that's a patient on insulin or on any agent that could cause hypoglycemia, you definitely want to get a CGM at least once to make sure they're not looking like this patient up here, but are more like this. Now, if we put a CGM on this patient, as some of you had indicated, it now gives us that complete picture. We find out that this patient had some highs and had some lows. And if this was somebody on insulin or sulfonylurea and this was in the middle of the night, we would definitely want to address this. So CGM definitely gives us a more complete glucose profile. And so you can see A1C is helpful for that long-term monitoring, but for that immediate to know what's happening over a 24-hour time frame, that CGM gives us a much more complete picture. So how do you interpret CGM? When people look at CGM, they go, oh my God, there's so much data. What am I going to do with all this? It's too confusing. And the answer is it's not. It's very simple. Now, instead of looking at a logbook, you're just looking at lots of glucose data. So we had to have a way to make this simple. And the way we did is we thought about where do we want those glucose levels to be? The target range is 70 to 180. That means after a meal, you want it under 180. And I would like you to remember 70% as the magic number. So we want 70% or more of the time to be spent with glucose values in the 70 to 180 target range. So again, our target range for glucose values is 70 to 180, and we want our patients to be there more than 70% of the time. And all of you are, I'm sure, used to the goal A1C of 7. Where do we want to go? 7 or less, or as close to normal as possible, as long as they don't have comorbidities. Well, a time in range of 70% correlates to an A1C of 7. So the next time you're looking at a CGM, you look at those data and you look at where they are for target range. You want it 70% or higher because you want their A1C to be around 7 or lower as long as they don't have comorbidities. And the next thing you want is you don't want them to have hypoglycemia. And here it says less than 4%. I personally like it less than 1%. So those are the 2 numbers that you just need to remember, that time in target range, 70% or more is an A1C of 7, and then hypoglycemia as little as possible. Now, what about older patients or patients who have, limited lifespan or a lot of comorbidities? What do we want to use for that A1C? Well, typically we say, around 8 is okay for them, 8 or less, because we're not looking for tight control in that age group because they have comorbidities or a limited lifespan. And that correlates with the time and target range of 50%. So an A1C of 8 is a time and target range of 70 to 180 of 50%. And just for reference, what does this mean? There's all this percentage stuff. Well, 1% of the day is 15 minutes. So again, remember, magic number is 70%. Time and target range of 70 to 180 is 70%, A1C of 7. So now let's move on. When we look at this report, we have an AGP. And the reason it's called AGP is ambulatory glucose profile, but also because endocrinologists like mnemonics, just like we have EKG, we like to have something too. So we call it an AGP. So when you look at it, I'm going to show you how we interpret it both ways. First, how you as a clinician look at it, and second, how you explain it to a patient. So when I look at it as a clinician, the first thing I want to know is make sure that the patient was wearing it. So I look at the percent of time the CGM was active. Remember, our magic number was 70. So we want to be sure they're wearing it 70% of the time. Then I go to my time and target range, 70 to 180. What's our magic number? 70. So we want it there 70% of the time. And then I don't want them to be low. So I look to see how much low they're having. And here you see 3.1% of the time they were low. Next, I look at this huge graph. So here is the glucose level. Here is time of day. And here are the median glucoses. So I quickly look and say, oh, this person midnight to 8 a.m., not doing too bad, within that 70 to 180 range. And then you see, oh, at lunchtime, they're a little higher. And so you kind of get an idea of what you might be wanting to ask the patient. And then these show you the outliers. This is the dash green lines are the 10 and 90% quartiles. And the blue is the 25 to 75. But really what you want to do is kind of focus on this median one. Then you want to dive into each day. And this is a daily report. So here's day by day. Here's again the glucose, time of day. And then you can see where it's high in the orange. You can see where patient has put in some events or checked. And so then you can start to go into further detail with the patient. So going back to this, when I'm talking to the patient, how do I tell them? The first thing I do when I'm talking to the patient is go to the visual. I say, hey, these are your glucose levels, and this is time of the day, and the red line is where you are most of the time. Then I tell them, it looks like you're pretty good from midnight to 8 a.m., but you tend to be higher after lunch. Tell me a little bit about your lunch. And then we can have that conversation. And then I also go here. I don't talk about the time it's at, the CGM's active, that's unless it's less than 70%. I then go to the time and target range. I don't tell them at that point that the goal is 70, but I just go, this is about 58%, and we do want to get that a little higher. Typically between visits, you're trying to get, if you're seeing them in 4 to 5 weeks, like a 5 to 10% increase in time of range. And then if there's some lows, I talk about that. Then I jump to the daily report and have that conversation with the patient. So that's how we interpret it with the patient, allowing that conversation to happen so we can find out what exactly is going on. So before I move on, I just want to see if there are any questions. You can put them in the Q&A or raise your hand. Any questions on that interpretation?
There is a question in the chat. Is there a role for CGM in patients that are on regimens that are low risk for hypoglycemia, GLP-1s, metformin, SGLT2s, etc.?
Excellent question. So yes, there is a role, and the role is there are two roles for it. One is if the patient's A1C is not at goal, putting them on a CGM one time will help you as a clinician to know exactly what medication adjustment you need to make. The second role is really for the patient to understand what's going on. Because we know, as I'll show you later, is that one size does not fit all. Everybody responds differently to different foods. And so what we like to do is put every patient, if you can, on a CGM at least once. And during that time frame of that first week, have them log their food so they can look and see what foods make their glucose go up and what doesn't. And it's different for every patient. I had a patient who loved his carbs. And so we did that. And he found out he could eat his pasta, he could eat his bread, he could eat his sushi, but only potato chips made him go up. And it was a huge burden taken off. He said, I don't care about potato chips. I'm going to throw them away. But he was glad he could eat his other foods. And then they can experiment with portion size. They can experiment with physical activity. Like one patient found out a 10-minute walk did nothing to her blood sugar, but 30 minutes helped. So now she goes for 30-minute walks. So by doing them, you help them to make the behavior changes and you find out what is right for them. So the answer to your question is twofold. One is really getting the patient to know what kind of foods react with them, physical activity reacts with them. And the second is for medication adjustment. So I believe there's a role for at least a one-time CGM wear. And there is a way you can get it for each of your patients through Abbott. They have a program where you can get one CGM free. Excellent question. Any other questions? Okay, so we'll go into, this is a patient with type 2, and he is on basal bolus insulin. And again, here is my glucose levels, here's time of the day, and I just showed this to the patient. And I didn't say anything, and it's in color. And he said to me, Dr. Reddy, I'm all over the place, aren't I? I go, yes. And then I told him that each of these colors is one day. And then he goes, oh, over here, Dr. Reddy, I went out for ice cream with my grandkids, and that's how I was high. And I go, what happened here? Well, I'd gone out for something else, and I was worried I'd be high, so I took some extra insulin. And then he started saying them up and down. He said, I wondered, then he actually asked me if he could get one of these so that he could figure out whether or not he should take his insulin and he could see where he actually was. So he was really having trouble knowing, should I take my insulin or not? He was scared to take it sometimes didn't know how much to take. Other times he wasn't sure when he was physically active what he would do. So he really wanted a CGM to help him with knowing whether to take his insulin, how foods reacted, how physical activity reacted. And that's where he was. So he saw the value of it when he saw what was going on here. So the question is, how do we help this patient? And really, a couple things. First, finding out how different foods react to him, because we know now that one size does not fit all. Like I alluded to with my patient, everybody is different on how they respond to food. We know for a fact there's inter-individual variability. In the past, we kind of told all patients, can't eat this, can't eat that. That's not true. There's value to having them wear. And then that real-time feedback changes behavior and also empowers the patient. And in your patients on insulin now, you can also calculate the dose of insulin, or they can see, when I eat cereal, I tend to go up higher. Do you think I should add an extra unit? They'll be coming back to you and asking you those questions. And then patients need to understand, if they're in a basal bolus regimen, how it works. And by putting the CGM on them, they start to understand. And I know all of you are familiar with this. The way I explain it to the patient is I tell them, when your pancreas was working properly and you did nothing but sleep all day, it made a drop of insulin every minute to keep you normal. And that is your basal, which again, depending on what you have the patient on, you can tell them that's your Lantus or your Toujeo or Tresiba, which means that if your dose of Lantus, I'm using that as an example, is correct, your blood sugar should stay normal even if you didn't eat anything. Then I move on to tell them that when your pancreas was working, it made a blip of insulin with each meal to match what you're eating. And that's what we're trying to simulate with whatever, again, use the example, you have the patient on Humalog, Novolog, regular. And so we want to match it. So if you're having a small breakfast, you'll need less insulin. If you're having a big breakfast, you need more. And so they start to get this concept of understanding how they're being their own pancreas. And that's why I say, I want you to understand this so you can be your own pancreas. And then all of you are familiar with the pharmacokinetics of insulin. I just put this up as a reminder because we have some patients who'll take their Novolog or a P-drop after meal, or we even found out when we did questionnaires on them, when do you take your insulin? Oh, you told me I need to take it 3 times a day, so I just take it 3 times a day. And they were taking it not with regard to the meal, but at clock times. So it's very surprising what you find out. So I let them know that. And then for the Lantus or the basal, the Tresiba, Toujeo, because it's a flat insulin, I always ask them, what's the time of the day that you're home and you're awake? Because it doesn't matter when they take it, as long as it's around the same time, give or take, 1 or 2 hours every day. And that makes it easier for them to be adherent to that regimen. So how do you help this patient? Well, he has a CGM. He's going to be more likely to take his insulin because he knows how he's going to respond. He has now seen the effect of food and physical activity. He understands how insulin works because we've gone over the basal bolus and given him some of the basics. You could also, if you wanted to, if they say I'm stressful and I notice sleep is an issue, that does affect it, but that would just be a consideration. Once you've educated the patient on this, now we want to move to how do we use these trend arrows to adjust the insulin dose? So this is what the trend arrows look like on a Dexcom. You don't need to memorize this. All you need to know is if it's flat, that means staying level. The diagonal one, slowly rising, and the two up ones just means it's going up fast. This is slowly falling, and this is rapidly falling. Libre has similar arrows. You can see it better here. Again, it's flat, rising slowly, rising very quickly, falling slowly, falling quickly. So it doesn't matter if they're using a Libre or Dexcom, there are similar arrows. So there are different methods that have been used. I personally like the direct neck method. I find it's the simplest, and all of these are really starting points. So what I'm going to go over with you today is the direct neck method. And it's really simple. So think of that patient that I used in his example who took 10 units of insulin for his breakfast every morning. If he's ready to take his insulin and the arrow is flat, he would take his 10, assuming he's normal glucose. But if the arrow was a diagonal one, instead of 10, he would increase it by 10%. So that would be 11. And if the arrow was going straight up, he would increase it by 20%. So that would be 12. And similarly, he would decrease it if the arrows are going down. So let's start with an example, and I'm going to have you give me the answers here. This is a patient who weighs 100 kilos. He's on glargine 30 units daily and Lispro 10 units before each meal. This is a typical way that I've used to calculate insulin dose. I use it as 0.6 units per kilo. This is for a patient with type 2 diabetes. I use the basal dose as 0.3 units per kilo, and the prandial, in this case Lispro, 0.3 units per kilo, and that's divided into 3 doses. And the correction dose, I used a target glucose of 150. The correction dose is 1 unit of insulin, drops the glucose 25 points, and this is based on a 1500 rule that we commonly use with pump patients. So again, this is a formula that's commonly used to calculate insulin doses. Again, 0.6 units per kilo, divide them equally as basal and bolus. So here's our patient whose glucose is now 100. He's on Lantus, 30 units daily, Humalog 10 before each meal. So here's the arrow so we'll go with each one. So if he's ready to take his insulin and the arrow is flat, what would he take? 10 units. Okay. So if it's slowly rising, what would he take? Let's go ahead and put that into the chat. Anybody? All right, let's see what we got. Francis, 11. Yay, everybody's right on. Okay. Sorry. And if it's rising, what would it be? Can you put that into the chat again? 12. All right, we are good. 12 units. And if it's rapidly rising, 12 units. Again, you just need to remember if it's going up, it's 20%. Okay, so let's go to this patient now. It is slowly falling. So how much insulin would he take? Go ahead and put it into the chat. 9. Awesome. You are going to be pros when you're done. How about for these two now? If it's falling or rapidly falling, what would this patient take? 8. Perfect. Yep, so that's what this patient would take. Okay, so let's go to another example. Okay, this one's going to be a little trickier. There's this same patient again. The glucose is now 350, and he's ready to take his insulin. This target glucose is 150. The correction dose is 1 unit for every 25 above 150. And so you do 350, because that's what he is, minus the target, 150, so that's 200. Divide that by 25, so he needs 8 units in correction. And then for the meal that he's going to eat for that carbohydrate, he needs 10 units. So how much would he need if the arrow is flat? Again, go ahead and put it in the chat. Okay, everybody is paying attention. Nice, 18 units, perfect. What about if it is rising slowly? Please put it in the chat. Good question. Should it be 18 or should it be 19? Those are excellent questions, because really you're increasing it by 10%, which would be you take the 18 and you do 1.8. So then you would just round it off to the nearest number. So it would be 20. And here, if it was rising quickly, it would be 20%. So that would be like 3.6. So again, rounding it off, you wouldn't be wrong to say 21 either. Okay, so let's move to the next one. Okay, we talked about if it was changing slowly, that was going to be 18. And if it was falling and you decrease it by 10%, I kind of gave that one away. And what about if it was falling quickly? What would that be? You can go ahead and put it in the chat. Perfect. 14. That's it. So you can see how easy it is to use this method to teach a patient or to do it. So before I go on to how do you set the patient up for success, now you know how to tell the patient. How do you make sure the patient can follow what you're doing? Does anyone have any questions? I'd be happy to answer those.
Sushma, there is one question in the chat from previously.
Sure.
Any ideas to keep CGM on the body? Many patients come back that it fell off.
Sure. There is something called Skin Tack that you can get. You can order it on Amazon. So if you're using the Abbott Freestyle one, especially, we had trouble sometimes with those Libres falling off. So you get the Skin Tack, it's like a sticky glue thing, and you can just wipe it around the area you're going to put it on, and then you put the Libre on and it stays on. And sometimes you need something to take it off with a Unisolve thing, otherwise it comes off. So that's what we've done. They also have over tape that you can put. Dexcom has it as well as Abbott, so you can tape on top of it. You don't want to tape on right where that sensor hole is though. So both of those work really well. And both of the companies, if you ask, I think Dexcom sends you the over tape. I'm not sure about Abbott, but both of those are available. Other questions? Okay, if not, I'll move on to how do you set the patient up for success? So they come in for their office visit. You have to have a way that you can automatically download, if possible. If your patient does have a smartphone, it would be nice to hook them up to whatever system you're looking at so that you're not wasting time trying to download it. If not, at least have a system in place for your workflow that's quick so you're not waiting for that download. And then the next thing is you want to make sure that the patient understands everything. You know, do they understand how what those arrows mean? Do they know how insulin works? Do they understand about nutrition? And do they always have food to eat? And we actually did a therapeutic CGM training program in our office, and the questions I'm going to show you are from that. And I was so surprised at some of the answers I got. So I will go over that with you. And you want to address any areas of concern, and then you can use the method we just talked about to adjust their insulin dose. So here's an example of questions. This is one of the ones we asked them. When one arrow is pointing up, what does it mean? And here's where patients were very confused. There was one patient who thought she needed to eat and make her blood sugar go up. So you want to make sure that the patients know what that arrow means. And then we did this one. Mr. Smith is going for a 1-mile walk. And I just used Dexcom as an example. You could use Libre, whatever you want. It shows a blood sugar of 90 with 2 arrows going down. And it was amazed that people gave all different answers. Not everybody thought that he should have a snack before he goes for a walk. So again, it's important to know that your patients know what those arrows mean so that you're preventing hypoglycemia. And then you want to know that they know how often to change their sensor. You'll be surprised. I had one patient who actually used the meter, used the same Lancet for a year. And he finally said, Dr. Reddy, this thing is kind of blunt. I'm like, why is it blunt? He goes, I've been using the same one for a year. I'm like, oh my God. So it's very surprising what patients do. So you want to make sure, depending on the sensor, they know how often they need to change it, although the sensor will run out and warn them as well. Then you want to make sure they understand insulin action. And you want to, depending on what insulin you're using, you want to know that they understand how quickly it starts to work. For example, I had patients when Humalog first came out, they would take their Humalog at home and then go to the restaurant and eat. And unfortunately, before the food arrived, the ambulance would arrive because their Humalog would start working right away and they would have passed out, thinking that their insulin doesn't work that quickly. So it's very important that they know how soon their insulin works. And it's important that they know what time to take it. I've had patients say, oh, I take it after I eat, like an hour later, or I take it at 8 in the morning and 6 in the evening. Why? Oh, because it's that twice a day time without regard to the meal. So you want to make sure that they're taking it with their meal or that 0 to 50 minutes or just when they start eating, so they know to do that. And it's also surprising when you ask them what foods make a blood sugar go up. They have no idea. And especially, I live in Michigan. People love their corn. They go, "Oh, corn's a vegetable. It can't make my blood sugar go up." And they're eating a lot of corn and they're wondering why their sugar's high. So it's important that they understand what carbohydrates are. And rather than saying what's a carb, it's just like what makes your blood sugar go up. And then food scarcity. We would have in our office, patients would come in and I'd say, "Do you have any trouble getting food?" They go, "No." But we had a lot of food giveaways. And I would say, "We have a list of food giveaways." "Oh, Dr. Reddy, could I have a list of that?" So patients don't often come out and talk about food scarcity. But again, where you are, you're used to that. So you probably already have that built in. But these are standard questions for food scarcity, to know that. Because obviously, if they're not getting the right food to eat, there's no way you're going to be able to adjust their insulin unless you know they're getting a meal. It becomes very difficult to adjust it. So before I go on to basal insulin, any questions on that? How you set your patient up for success? I would comment that with where you are, having worked with Laura, I know some of your patient profiles. And so you could also have, like, when you have, depending on what food they have available to them, it could be like when you have the cereal available to you, here's what insulin you take. But when it's not available to you, here's what you take. And you could then have different options. If you've had them wear a CGM once and track some of their food, you now know what to tell them for their insulin dosing. Any other questions? Okay, and I will move on to basal insulin. And this is the MOBILE study. This is a study that was done really looking to see if CGM is of benefit to patients on basal insulin. It was done in a primary care practice with endocrinologists helping with some of the management or giving suggestions for the diabetes management. So there are 176 patients, 2-to-1 randomization. This group was on CGM. This group was just on blood glucose meters. And they looked at their data at 12-month A1C and at 32 weeks as well. And it was a pretty diverse group in terms of ethnicity. You had 43% white non-Hispanic, 30% Hispanic or Latino, 21% Black non-Hispanic, different education levels, and different insurances. So a diverse group of patients. And the primary outcome was the A1C at 8 months. And the baseline A1C, the CGM group, was 9.1%, 8% at 8 months, and the adjusted difference was 0.4%. And when you look at this at the time in range of 70 to 188 months was 59% in the CGM group versus 43% in the blood glucose monitoring group. And more importantly, not on the slide, which was interesting, is that there was no difference in insulin dose between the CGM group and BGM group, which means that a lot of this was behavior change. So this is how, based on this study, is how the insurances, Medicare and Medicaid, now covers CGM for patients who are on a basal insulin. So how would you titrate basal insulin using a CGM? So first of all, the patient needs to understand how that basal works, whether it's Lantus or Tresiba or Toujeo. And again, you want to ask them, what is a time that you're always home and that you're always awake? Or in the case of your population, what is a time that it's easy for you to always take your insulin? When would you remember? And so that's the time that they take their basal every day, give or take an hour. Next, we need to show them how to adjust the insulin. So I'm going to show you 2 algorithms, and you can decide which one you like to use. So first of all, you individualize what you think that fasting glucose target is for the patient. This is an example, 80 to 130. I usually just ask the patient, where do you feel comfortable at? If they feel comfortable at 150, I might say 100 to 150. If they feel 200, 150 to 200. So you go with what the patient is comfortable with, and then you slowly bring it down to where you know it's supposed to be. So this is what we mean by individualize. So this is option 1. This is what the ADA recommends. They want you to adjust the dose by 2 to 4 units, once or twice a week to reach the target. And if the patient has a low glucose, then decrease by 4 units or 20%. Personally, I find it's difficult for patients to remember once a week, twice a week. I mean, they're looking at the data every day. I feel like they should be doing something every day. So this is what I personally do. I just tell them if they're not at goal, every day increase it by 1 unit or 2 units. You could pick what you think is appropriate based on the Lantus dose. So if they're on a large dose of Lantus, you could say a 2-unit increase. If they're on smaller doses, just let them increase it by 1 unit every day. And if they have any hypoglycemia, tell them to cut their dose down by 20%. And sometimes it's hard for patients to think in percentages, so just say by 4 units, or whatever you pick would be 20% for that patient. So this one is what I find personally much easier to do and easier for patients to follow because they're doing something every day. Any questions on the basal insulin titration? Right. I'm going to show you some case studies of where CGM has been extremely helpful. This is one of my first patients who was 60 years old. She was on glimepiride, sulfonylurea, metformin, and pioglitazone. Her A1C was 9. But on her meter, her fasting glucose was 120, and she would actually drop low before dinner. I didn't believe her. I said, your meter's not working. I had her bring it in, and it was working. So we put a CGM on her, and this is one of the older iPros, like from almost 20 years ago. And this is, again, glucose. This is time of day. Each color is a day. And surely between midnight to 6 a.m., she was pretty much normal range. You can see the 120s. And before dinner on those days, she was in the 80s. But look what happened after breakfast. She spiked to 400. And because we were only checking before breakfast, before dinner, I mean, we had no clue. So without this CGM, we would have never figured out what was going on with this patient because it's hard to get somebody to check multiple times a day. It turned out she was eating the so-called good cereal. And in 25% of my patients, cereal will make their glucose go up. And so we adjusted her regimen and her A1C stayed close to 7 for the next couple of years. So you can see how that one-time CGM use is all this patient needed to make that adjustment. So for sure, again, going back to that previous question, if you've got somebody with an elevated A1C, definitely a one-time CGM use is very, very helpful, even if this patient is not on insulin or not on something that would cause hypoglycemia. So here's a very interesting patient that I would like to see how everybody would treat. He's 55 years old. He has fatigue and polyuria, no fever, no chest pain, no shortness of breath. He was seen by the primary care provider, clinician in the clinic. This is a patient I saw at Carbon Health where we had a continuum of care between the primary care clinicians and us. They would see the patient, get them started on CGM and metformin, and we would see them later. But this is a patient that she saw. He was 431. Point of care A1C was 14%. So time for a poll. In addition to starting the patient on CGM, because this is what we did, what else would you prescribe this patient? So I would love to see what everybody's answers are. Again, remember, A1C is 14. Fasting glucose there was 431. So would you start the patient on a basal bolus insulin there? Would you start them on metformin alone? Would you start the patient on metformin and a basal, or would you start a GLP-1 and basal? So again, this is a real patient. And again, we had over 46 primary care clinicians all over California that would see patients in person. And we would then see them virtually, usually within 2 to 3 days.
Just a few more seconds here and we'll close the poll. Okay, ending.
Okay, some of you would start on basal bolus insulin, some would start on metformin and basal, some would start on GLP-1. And you know, all of these answers are correct, but let's see what actually happened with this patient. It was very interesting and it was very fascinating to us. So again, like I said, this is what happened. The patient was started on the CGM on November 2nd and metformin. So this is an Abbott Freestyle. And you can see this is this gray shaded area, 70 to 180. You can see this patient is way up here, 300s, 400s. But look what happened. This is November 2nd that we started the CGM. We saw the patient on November 5th and we were shocked. We're like, A1C 14, glucose 431. This person is normal in 3 days. We know metformin doesn't act that quickly and doesn't bring you from 431 to 180. We're like, whoa, what is going on here? And so we went here and we talked to the patient. So this was right around Halloween time. He had a family history of diabetes and he was eating candy like it was going out of style and he was drinking a lot of pop. So the moment he saw this, he was like, oh my God, this is my wake-up call. He threw away his sugar, he threw away his candy, and he started exercising. Look at this. Remember, November 2nd is when the CGM was started and metformin. He normalized. So he totally changed his behavior with the CGM. And so we then found that we had several patients that did exactly the same thing. And again, the standard of care would have been to start him on 2 agents, which is what all of you kind of suggested, either basal bolus or basal or a GLP-1. But we saw something different happening in our patients. So let me move on to the next one. And these were 6, we had 15 such patients that we noticed, and then these are 6 that we presented in Berlin at the ATD conference. And you can see all of them started out with a baseline A1C of over 10. They were all started on CGM and metformin by the primary care clinician. And we saw them within 3 or 4 days. Look at their time in range in that very first week. Over 70% in 5 of them. And look at them at week 2. All of them had a time in range of over 90%. And look where they started in 2 weeks. So what does this mean? This means that if you have somebody in your clinic who you think you want to start on a CGM and you're going to see them in 2 or 3 days, or you could monitor them in some way, it would be fine to do that. Otherwise, I would not recommend doing it because it's not standard of care. But I show this to you as to show you how much behavior change you can see with CGM. And so these patients, actually 5 of them were metformin, and 1 of them was just lifestyle at the end of 2 weeks. And then we followed, our median follow-up was 18 weeks. And in fact, I have 1-year follow-ups on 2 of these patients. They continue to maintain that time in range with metformin alone. Amazing. And these are patients who would have ended up on multiple medications. So if you have a patient that does not look like they need to be on more than 1 medication at that point in time, that you can follow up and you can watch them, maybe they will fall into this category where they don't need multiple medications, but would be controlled with something as simple as metformin. So just keep this in mind. And this data is also published in Clinical Diabetes last July. So how do you incorporate CGM into your clinic workflow? I would suggest, if it's possible for you, to consider starting all patients on CGM at least once. If any of your patients have insurance, a Medicaid or Medicare or some kind of a commercial, then you could use a Dexcom G6 Pro or Libre Pro. The cost of each sensor is $59 and you can bill for it. If they don't have insurance, Labit has a program called My Freestyle where you can get a free sensor. And if your clinic does have some grant dollars that they would like to use for patients who are totally uninsured, there is an indigent program where you can get a sensor for $25. And then the Libre lasts for 2 weeks, the Dexcom for 10 days. So during that time, have the patients log their food, their physical activity, their medication. Have them see you in a week. So you can look at that, make some more changes. And if they do have insurance and they're on insulin or hypoglycemia, then their insurance will cover their CGM. So this is the My Freestyle program that you can go to, and it is really 1 free CGM per lifetime. The patient does need a smartphone. If they don't, your clinic could purchase a reader, and you could give that out with each patient. So that's the thing, but you cannot use this for Medicaid patients or Medicare patients. Although if you do have Medicaid or Medicare, these patients, if you had a G6 Pro, for example, in your clinic, you could use that to put on them and you would be reimbursed for it. So again, if you think about it a different way, you want to think about no insurance, use the voucher program or indigent program. If they do have insurance, think about whether you want to get like a Dexcom G6 Pro. And if they're on insulin, then they should have insurance coverage. And we also do have a MAVEN CME about how to set up a CGM program in your own clinic to help you with kind of the nuts and bolts of that if you'd like to pursue this further. And then when you view this data, you need to have a way to view it. You could have the Dexcom Clarity for Dexcom, Libre View for Libre patients, or you could have one platform such as Tidepool or Gluco. Tidepool is free for up to 250 patients, and on Tidepool, you can also view pump data. So those are things to keep in mind that would be helpful. If it works for your patients, there's also a way to do remote patient monitoring using these platforms, where you can then be able to look at their data, do medication adjustments, and there is reimbursement for this for some of the insurances as well. So just to remember that that is a possibility as well. And this is a little bit about Tidepool. And this is just to show you that there is reimbursement. And this is if you did put a sensor, for example, this is what Medicare would pay. So it would obviously help with its cost as well. And there is reimbursement for remote patient monitoring as well for many of the insurances. Before I go further, I'd like to answer any questions so far. See, there's some in the chat.
I think the first question is, in your experience, how durable is that behavior change?
So in my experience, the follow-up we've had is it has been durable for up to a year. It almost seems to me, it's kind of like if you catch them at the beginning. So when they're first diagnosed, there's this motivation to do something, or that first encounter that you have with them. So if you put the CGM on them that first time, and they see that and they're empowered by use it as an educational tool as well, I would say that over half of the patients are motivated to maintain it. But we all know that diabetes is also a progressive disease, so there may be things outside of their control. So I would say in my personal experience, about 50% of them do maintain that.
Okay, there's a comment from Laura Curry about owning the Libre Pro in her clinic. And then another question, how much insulin do they need to be on before metformin is of no additional benefit?
Great question. So you need to think about the mechanism of action. What metformin does is it decreases insulin resistance. So if a patient is on metformin and also needs insulin and is truly a type 2, they usually need to be continued on metformin. I've been around for a while, for over 30 years practicing, and I remember when metformin was not available, we would put type 2s on insulin and I couldn't get them to go. And they would swear they're taking it, they're doing everything, but they have insulin resistance and increase hepatic glucose production. And when metformin came around, I put them on it, I was able to get their A1C closer to goal. So if your patient truly has type 2 diabetes, they do need to continue that metformin while they're on insulin because it decreases insulin resistance and helps the insulin to work, thereby to work better. You may be able to decrease the dose of metformin to say 500 twice a day versus 1,000 twice a day, but I would still continue it. Other questions?
I'm not sure. There's a comment someone asked earlier about keeping the CGM on the body because some patients have reported it fell off. Maybe if you could just quickly review the methods that you suggested for keeping CGM on.
Absolutely. So one is using Skin Tech. So Skin Tech is kind of a sticky glue kind of thing that it comes as a wipe. You can order it on Amazon. You can just put it around in the area where you're going to put the sensor and then put the sensor on. The second way is to put over tape. Both Dexcom and Libre have over tape that you can tape over it, but don't tape it on the actual hole where the sensor is, but like around it. So those would be the two methods that are easy.
Thank you. I think that's all the questions.
Okay. So the question next is, what's the clinical evidence? Because if you're looking at a clinic and you've got limited resources, you want to know that if you're using CGM, you're preventing hypoglycemia or preventing hospitalizations, because we all know how much one hospitalization costs. And if the CGM use in the clinic prevented one hospitalization, that's going to help with costs. So let's take a look at that. So this is the HypoD study, which was one of the first studies done several years ago to see whether the use of CGM can reduce the occurrence of severe hypoglycemia. This was done in Germany in over 6 different clinics. In red, you have the control group. In blue is the CGM group. This is the baseline, the number of events per 28 days. And at follow-up at 6 months, you can see that there was over a 70% reduction in the number of hypoglycemic events. And we're talking about severe hypoglycemia, less than 54, from 10.8 per 28 days to 3.5. And when you look at nocturnal hypoglycemia, that also decreased significantly from 2.3 to 1 event per 28 days. So again, showing that CGM significantly prevents severe hypoglycemic events. This is a study published more recently in JAMA in individuals in the United States. They're both men and women, older population, 68 years old. They were all on insulin. 203 patients, 103 on CGM, 100 on blood glucose meters. And you can see in the CGM group at baseline, they spent 5.1% of their time in hypoglycemia. But at 6 months with the use of CGM, that reduced to less than 2.7% of the time with a glucose of less than 70, whereas in the blood glucose monitoring group, there was no change whatsoever. So again, showing that use of CGM helps to prevent hypoglycemia. Now, what about hospitalizations? Now, this is data in the United States in patients with type 2 diabetes. And they looked at their incidence of acute diabetes events and all-cause inpatient hospitalizations for 1 year before using CGM, and in this case, it was a Freestyle Libre, to 1 year after. And you can see that acute diabetes events decreased by 61% from 0.18 to 0.072 events per patient year, and all-cause patient hospitalizations also decreased by 32%. So again, by using CGM, we're decreasing hospitalizations. I really like this study. This is a study done in France. And this was done in both type 1 and type 2, looking at hospitalizations for DKA. Again, looking at hospitalizations 1 year prior to use of CGM and 1 year afterwards. Again, it was a Freestyle Libre. In blue is type 1, and in the hashed lines is the type 2s. So here you can see there's a 52% reduction in hospitalizations for type 1 before and after, about 47% for type 2s. But here's what I found the most fascinating. Look at this group. These people were using 5 or more strips. So before they got a CGM, they're already checking 5 times a day. Like they're those patients who are very adherent, doing what they're supposed to. But even in this group, there was a more than 50% reduction in hospitalizations following the use of CGM. And interestingly enough, in the UK, they did another prospective observation. This is, again, observational study. There were 900 patients who had diabetes for over 20 years. And they also found that there was an 80% reduction in DK episodes following the use of CGM. This is kind of a fun thing. Earl Hirsch is an endocrinologist who likes to do calculations, and this is what he presented at whatever symposium that I thought was kind of interesting. This was back in 2020. At that time, the current cost of DK was in the US was 5.73 billion. And then he kind of did the math. Let's assume that all patients are using CGM and we reduce the episodes by 80%. Here's what our savings would be, $4.8 billion. And the ADA updated its standards of care in 2024. It already had that CGM was a standard of care for patients on insulin, that is multiple daily insulin injections or CSI. We now have basal insulin added. And here it also talks about periodic use of CGM can be helpful. And that's what we were alluding to earlier in patients who don't have hypoglycemia or not on insulin, kind of a one-time wear to adjust medication or to give that patient empowerment and that behavior change and have them find out how they respond to different foods or physical activity is very helpful. And that is now in the ADA standards of care, saying where it could be helpful in circumstances where consistent use of it is maybe not desired or available, but a one-time use or periodic use could be beneficial. And these are some resources for you that you'll have in the slide set. We have a lot of different CMEs on diabetes. Please do take advantage of these. And I would be happy, I will stop sharing at this point and be happy to answer any other questions. And great question. Even one-time use can make a change? Absolutely. Even a one-time use can make a change. I've seen that more so in pre-diabetes, actually. I've had people make tremendous changes and get themselves back to normal. But yes, a one-time use can definitely make a difference. I had somebody with diabetes who wasn't sure what he was supposed to do or take. He loved having his drink in the evening. He loved his different foods. We had him vary everything. One day it was gin and tonic, one day it was his wine, one day it was his beer. He found out the beer made him go up, so he got rid of his beer, but he could still have his other drinks, which he was very happy about. He found out a certain bread worked well. The other bread did not. He changed all his habits and his A1C normalized and changed, and it was a one-time wear. So yes, a one-time wear also can make a difference. And you'll find if your patients find value out of it, they may ask, can I wear it one more time? Or can I wear it again? But often just a one-time wear is all they need to know what they need to do.
While we're waiting for other questions, thank you so much, Dr. Reddy, for such a clear, concise presentation, reminding us all how important CGM can be in the care of type 2 patients, because I think we're all used to it in type 1 and we know it's a standard of care, but to think about it in type 2 takes an extra amount of commitment. So thank you so much. Any other questions here before we wrap up? And Dr. Reddy, you do have at least one other presentation on CGM in the MAVEN library. Is that right?
Correct, yes.
Okay, about setting up CGM in your clinic. And I know Dr. Reddy would be willing to communicate with any of you anytime about this subject about which she is very passionate. Okay, any other questions? If not, I'm going to stop recording here and thank you all for coming today and have a good rest of your day.
Thank you, everyone, for coming.
Okay. Bye-bye then.